Now, let's talk about a phrase that scares people more than it should. Pulmonary infiltrate. If you saw it on an X-ray report and thought, is this pneumonia? Is this cancer? Take a breath. In most cases, infiltrate is not a diagnosis. It's a description of a shadow on an image. Meet Mykola, 72. He went to clinic because he felt off for a week. Not dramatic, just more tired, less appetite, and a little short of breath when walking to the kitchen. They did a chest X-ray. The report said, right lower lobe infiltrate. Mykola read that one line and panicked. His daughter asked the best question, "Doctor, what does infiltrate actually mean?" Think of the lungs like two dry sponges filled with air. On an X-ray, air looks dark. When something replaces air, fluid, inflammation, mucus, a small collapse, this area looks lighter. That lighter patch is what people call an infiltrate or opacity. So the real question is not, do I have an infiltrate? The real question is, what is causing the shadow? In younger adults, pneumonia often comes with a clear story: fever, cough, chest pain. In older adults, the story can be different. Sometimes the first signs are confusion, a fall, sudden weakness, or a big drop in daily function. So we must connect the image with the person, not with fear. When doctors see an infiltrate in an older adult, we usually think in 5 buckets. 1. Infection, including pneumonia. This is common, but not the only answer. 2. Aspiration. That means food, drink, or saliva went the wrong way into the airway. This is more likely with swallowing problems, reflux, dementia, stroke history, or heavy sedation. 3. Fluid overload, or heart failure-related lung fluid. Sometimes the shadow is water, not infection. 4. Atelectasis, a small collapse. This can happen after lying in bed, shallow breathing from pain, or poor lung expansion. 5. Something blocking airflow. Less common but important, like a tumor or other obstruction causing a persistent localized problem. Notice something. One X-ray word can point to very different problems. That's why guessing at home is risky. Back to Mykola. A careful clinician does not stop at the X-ray. They check 4 things first. 1. Oxygen level and breathing rate. Low oxygen or fast breathing changes urgency immediately. 2. Vital signs and hydration. Low blood pressure, fever, or dehydration can change the plan.
3. A focused history. Questions like, did you choke while eating? Any new confusion? New swelling of legs? Sudden weight gain? Chest pain? Coughing up blood? Recent immobility or long travel? 4. Medication list. Some medicines can worsen drowsiness, swallowing safety, or fluid balance. Then, depending on the story, they may order basic blood tests, a test for infection if appropriate, sometimes a heart evaluation, and in uncertain cases, a CT scan to clarify what the plain X-ray cannot. If the person improves as expected, that is reassuring. But if symptoms persist, or if someone is at higher risk for an underlying problem, especially older adults with smoking history, many guidelines recommend a follow-up chest X-ray around 6 weeks later. Not because everyone has cancer, because sometimes an infection can hide an obstruction on the first image. Follow-up is a safety net. Now, the most important part. If you or your loved one has an infiltrate and any of these occur, severe or worsening shortness of breath, blue lips or confusion, chest pressure or fainting, very high fever with shaking chills, oxygen levels dropping, or coughing up blood, that is urgent. Do not wait it out. Mykola's case ended well. His clinician connected the dots: mild symptoms, lower lung opacity, and repeated coughing during meals. They treated him as a high aspiration risk. They addressed hydration and breathing support. They also arranged swallowing-focused evaluation. And they planned follow-up to confirm the shadow resolved. Within days, he was more alert. Within weeks, his walking improved. And the family learned a key lesson. One scary word on a report becomes manageable when you ask the right questions. Here are your take-home messages. 1. Pulmonary infiltrate is a description, not a diagnosis. 2. In older adults, symptoms can be atypical. Fatigue and confusion can matter as much as cough. 3. The right next step is not panic. It is structured evaluation and clear safety rules. If you want, I can prepare a short checklist for families. What to ask your doctor when an X-ray report mentions an